joined us. Couple of things to kind of get started. We'll talk about some housekeeping items here in just a second. I'm assuming, just because there's not a whole lot of people logged in tonight, the wildfires and some of yesterday's events probably took a toll on some of those EMS resources kind of across the region that normally tunes in for EMS live at night. So if people are joining in a little bit late, we'll kind of bear with them to make sure that they're not, it won't cause too much of a distraction. So again, welcome guys. What is happening this season? I want to take just a couple of seconds and just talk a little bit about some of the things that we changed for the 2020/2021 season. Super excited about this year for a couple reasons. Number one, I will not be teaching every single one of these lectures, which is the most exciting part for me. I did reach out and got some great speakers from actually all across the country. The one I don't want to put one above the other or anything like that, but one of the ones I'm super stoked about who offered up to do 3 different presentations is, if you're familiar with the Medic Mindset podcast, Ginger Locke will be joining us for 3 different presentations throughout the season. She comes to us or presenting from Texas. She's involved with the paramedic program down there. And like I said, if you're familiar with podcasts or any of the EMS podcasts, Medic Mindset is very widely popular kind of in the podcast, especially EMS podcast realm. So super looking forward to having her present. If you ever had a chance to check Medic Mindset out, you will know that her tone of voice, her voice in general, the way she speaks is infectious. So should be a really awesome presentation. The next one is my buddy Maurice Wagner will be joining us. Of course, we call him Mo. If you attended the Spring Fling Conference last year in Grangeville, Idaho, Maurice did present last year at the Spring Fling Conference, as well as he's also presented at the INHS conference, not last year, but the year before last. If you're familiar with I believe it was, I think the 4th of July pass amputation incident that was in GEMS magazine, as well as presented at our conference. Maurice was one of the paramedics involved with that call, so he will be joining us. I think he's got 2 presentations. Technically, he was supposed to present tonight on patient assessment, and sadly, due to some wildfire obligations, he was unable to present tonight. So we'll rope him back in for another one. But he shall be joining us for 2 presentations. Another speaker, a good friend of mine, Cameron Murphy, works for Spokane County District 9. He's a paramedic here in Spokane. He'll be joining us for a couple of lectures. Super excited to hear his kind of take on a couple of different topics. He's going to talk about diabetes. He's going to talk about, I believe, anaphylactic reactions and maybe shock and cardiac emergencies, something along those lines. Or I'm sorry, cardiac arrest management, I think was the other topic. So Cameron Murphy will be joining us for 3 different lectures this season. Mike Helmbach, who wrote the Sick Not Sick program, some of you might be familiar with, he's out of Seattle King County Medic 1. He's signed up to do 1, if not 2 presentations for us. We haven't quite got his dates locked in, so he'll probably be later in the season, the 2021 timeframe. The one he wanted actually was already picked by Ginger, so we got to get him signed up for a lecture or 2. So he'll be joining us this year for the first time. And then Ben Dill, who is a paramedic with, I think, Northern Lakes Fire, he'll be joining us. Awesome guy, fairly new paramedic in a new education role there with Northern Lakes Fire. He'll be joining us for 1 or 2 lectures, for sure 1 lecture. I think he's going to grab, I can't remember, traffic accidents or trauma emergencies, something geared in that region. Madeline Garrity will be back. She is a neurologist here in Spokane. She'll be joining us. If you missed her lecture last year, she's very active in the EMS realm when it comes to stroke and stroke care in the pre-hospital setting. She's super fun to listen to. She's got also an infectious personality. So she'll be joining us for 1 lecture. Again, she'll be a little bit closer to the 2021 time frame the 2021 year of EMS Live at Night. She'll be joining us for at least one lecture, just kind of trying to get her roped into a date as quick as we can. And then you'll have me for a couple of lectures, of course. I'm kind of that fill-in individual. If we can't get a speaker, then I will just grab some of those dates. If you got a pen and a piece of paper, or you're taking notes for your training agency, here are the list of dates. As always, EMS Live at Night traditionally has always been the second Tuesday of every month. We're going to continue that for September through June 8th. And then the rest I tried to throw on the fourth Thursday of every month. We had a couple of holiday conflicts, so we had to move those to Wednesdays. But you can see those dates up there. So mark your calendars. Please join us. As much as I possibly can, I'm going to try to record as many of these, and they'll be found on my YouTube channel. If you look at YouTube, you look for My Virtual EMS Instructor, I will throw the links up there. It cannot be watched for credit, but it is definitely something you can share with your agency or rewatch. It can be used as some of those individual hours that are under your NREMT and CCP guidelines, but it cannot be used for anything else. It cannot be used for Washington State OTEP, and it cannot be used for other sections of the NCCP model, but it can be used as those individual content hours. So take a look for those. Couple of housekeeping items I was talking about. I mentioned it just before the video actually started. There is a new roster found on our website, EMS Live, just the right where you click to get the link for this. On the left-hand side says current course offerings. Please download that new roster. That new roster allows me to track people logging in, what agencies you're logging in from a little bit easier. So please use that roster. That will be the end of class roster we'll use for the rest of the season. So you only have to print that once and then make lots of copies. Your roster does need to be submitted to us, and we'll talk about how we do that at the end of the presentation tonight, after each presentation. So please do not save those and submit at the end of the season. It makes our life a little bit complicated. So please do submit those rosters before we get too far into the week after EMS Live at Night. Note the link change, and of course, if you're in the presentation tonight, you noted the link change. This will be the same link that will be utilized for the rest of the season. If for some reason it does ask you for a password, by the sounds of it from our tech guru, Mark, who's joining us as always, the password's kind of auto inputted when you follow that link, so that shouldn't cause any issues. But on our website, you'll notice there is that password if for some reason it asks you for one. So please use this current link for the duration of the season. Last housekeeping item before we get started is please fill out the online survey. There should be a link under that current course offerings where you found your post-test as well as the attendance sheet for tonight. We do need a evaluation from everybody who attended. If it is just, like in the case of Stevens County where there's multiple people in one room, if you want to have each person sign in, that's fine, or you can input everyone's comments, that's also fine as well. But we do like your guys' feedback. It allowed us to pick new topics this year. The speakers you liked, the speakers you weren't a fan of, that we try not to invite back again. But it allows us to track a little bit and be pretty consistent with getting the content you guys want to see and keep this something that's driven by your guys' input. So we do greatly appreciate that. All right, if there's no questions, let's get started with tonight. Brogan, you got a question. Look at you. I got you. What do you got, man?
Sorry, in the past, we have done paper copies of the survey and faxed them in. Is that still acceptable?
Yep, 100%, man. That's totally fine. Cool. Thanks for bringing that up. Yeah, if you want to, or even if you throw it in an email or something like that, that's totally fine. The Survey Monkey allows it to be anonymous if you want an anonymous comment, but for the most part, hopefully it's positive enough that you don't feel the need for it to be anonymously mean, but there are those times. So yeah, that works totally fine. Thanks, man. All right, so tonight's topic is patient assessment. We're going to call this one Beyond the Skill Sheet. In complete transparency, I was not the scheduled presenter for tonight. I was just going to host, introduce you to some of the changes of EMS Live at Night, talk about some of the new speakers this year. Maurice Wagner, again, joining us from Kootenai County Fire and Rescue, sadly has some obligations with the wildland season. He was out all night and had some issues with getting this presentation completed for this evening. So he very nicely dropped it into my lap. So this presentation I kind of put together is meant to be a broad overview. I did manage to find something new from an article that was shared across social media today. In fact, it's dated today. It's a really interesting spin on Glasgow Coma Scale, and I'll share that with you. So there's a little bit of tidbit of new information in there. Hopefully this just kind of gets the gears rolling, gets you the mindset of patient assessment, what that's all about. Tonight's a little bit unique in the fact that I've got a scenario we're going to work through the duration of the time. So I need some input. So, you know, the guy in the yellow coat there in the Stevens County classroom, the mic's right in front of you. So you might have to hit the mute and unmute button. Everybody, he's ready to go. Everybody, you can throw it in the chat box. You can raise your hand in the participation window or unmute your mics. But I want to hear some interactivity a little bit from you guys. Mostly because it's no fun if I'm the only one talking. So help me out tonight and let's make this as interactive as we possibly can. Maybe get you out of here a little bit earlier, get back to your families, but we will kind of see. Harrington, I see you turned your camera back on. I think that's the one that happens to be in a hotel room. So hopefully you guys are a little bit more interactive than normal tonight. So let's get this thing started. So here's kind of our scenario. So you're dispatched to a viaduct for an unresponsive man. A citizen bystander reports a man acting strangely. The police are already on scene. So as you kind of arrive here, I've got another piece of information I'll share with you in a second, but you got this elderly male. He's sitting on a park bench. He appears to be unresponsive. So when it comes to patient assessment, where does our scene survey or our scene size up? Where does that actually start? I know that was one of your post-test questions. But what does people thought? Where does our scene size up actually start? What are your guys' thoughts? Harrington Annex, what is your thoughts, sir?
On the way to the call.
I like that. So on the way to the call, so what information are you using to drive that scene survey then?
Well, just what you're given. So an unresponsive man, and he's acting strangely. So you're going to just start trying to figure out from that aspect, you know, what the situation is. If it's like this picture where it's sunny outside, or it's nice, or is it wet, rainy, cold, that situation.
Yeah, I like that. What was your name, sir? I'm trying to call you on by name, but.
Justin.
Justin, all right, perfect. I'm gonna write that down just so I don't call you Harrington Annex, but yeah, Justin, so you're spot on there. And really it comes from your dispatch information, right? Dispatch would have told you unresponsive male, called in by a bystander, acting strangely, so on and so forth. So I love that. So your dispatch information really drives a lot of the information we're gonna get in scene survey. So
hey, Sean, there's also one other thing too, and that is the fact that the police are already on scene as identifying your scene safety, that we already have additional resources available to call on.
Yeah, I like that. Who was, your name doesn't pop up with that, so who was that?
That was Bruce. I'm up here in Stevens County with Steve Brogan.
Oh, now I see you. Okay, that makes sense because it came in, your name isn't up there. So now I got you. So Bruce, I'm going to try to do better at remember people's names. So I got names written on a little whiteboard here. So yeah, so the information, you got some additional resources already on scene. Law enforcement's already there. Of course, that can be concerning. You know, why is law enforcement there? Maybe this system, that's just the way it's based. But I like that. We got some additional resources there. We got some good information from dispatch. Now, I'm not always telling you to use dispatch information to get a clear path of where you're going, because I don't know about you, but I've been fooled by dispatch 90% of the time. It's not their fault, but it just tends to happen. But it is a good place to start. We start gathering some idea of what might be needed on these calls. So besides Justin and Bruce, I want kind of everyone to participate, so I like that. But besides Justin and Bruce, what kind of things can we start to, like, as we arrive on scene, besides weather, which Justin talked about, besides the fact we got some additional resources there available to us, like Bruce talked about, what other things might we use to develop what our scene is all about? What are other people's thoughts? What other things might we grab or pull from in order to gain some more information? What do we think? Anybody got any ideas?
Katie up here in Stevens County, she was talking about some gathering some equipment like such a glucometer for establishing a diabetic, because we don't know anything about the patient's background.
Okay, I like that. So maybe gathering some additional equipment in the ambulance, maybe a glucometer. You know, some agencies might have that all in one bag. You might have to grab some additional stuff. I kind of like what Justin was saying about if it's cold outside, maybe on the way to the call, you grab, if you're advanced EMT or EMT IV or paramedic, you grab some of those IV bags and huck them in the IV warmer on the way to the call. So that way you got some warmed IV fluid maybe to pull from, but definitely some possibilities there. So when we arrive on scene, think about address and location and maybe calls that you've been on in this region before. I'm sure I'm speaking from your guys' experience as well. There's maybe addresses or apartment complexes or regions or, you know, gas stations or supermarkets where some of the calls tend to be in similar chief complaints or similar problems, right? It's not always the drug house. I mean, there's definitely those in every region, but you might have an assisted living facility where there's, you know, some commonality in chief complaints, or a house that has a certain, you know, population that live there or something along those lines. One of the things that I'll add into this scenario is as you arrive to this scenario, you do note that there's kind of a homeless camp, that you know there's been a recent outbreak for tuberculosis. It's not too far away from where you're currently sitting. Maybe it's an area where the homeless population congregate or have made some sort of community of those individuals that are kind of hanging out there. Now, this scenario I stole from a different presentation. Let's switch the tuberculosis outbreak to maybe a COVID-19 outbreak. But scene size up is all about protection of us, right? That should be the kind of the underlying, thought process we're thinking about. So obviously in this case, maybe as you arrive on scene, you take a look around, you've seen this homeless encampment not very far away. You know, now this day and age with COVID-19 and other, obviously, you know, whether it's tuberculosis or COVID or something along those lines, donning that respiratory protection, those glasses, maybe the Tyvek suits, being a little bit more diligent when it comes to that body substance isolation and personal protective equipment that we're now so aggressively familiar with. So not really anything more than just that in this scenario, but we're going to don the proper personal protective equipment, the HEPA mask, N95 mask, and then go ahead and enter this scene. As we arrive, we enter the scene specifically. We got an unresponsive man sitting on the bench, police officer standing near the patient. He reports kind of the backstory. Utility worker saw the man stumbling along, sat down, and then passed out. As you approach the patient, you got a disheveled looking man who's approximately 60 years old, judging on that picture. An old shopping cart's kind of filled with his belongings is nearby. The patient doesn't make any attempt to move. He's not making any sounds other than some snoring noises as he breathes. He's got a radial pulse that's strong. There's no obvious bleeding or signs of trauma. So let's think outside the box a little bit here. What is this scene telling us? What are some information you're grabbing from this scene that you're going to use to progress through your patient assessment? What are your guys' thoughts? Justin, Bruce, Katie, you guys can pipe in. Somebody new, again, don't forget you can use the chat box. I only have a couple of videos up on the screen, so I can't really call on very many people. But what are your guys' thoughts? What are some things that are grabbing your attention that you might use during the duration of this patient survey?
Well, a couple of things that grabs our attention is his attire suggests that he might be in part of the homeless encampment. His lifestyle may suggest a lot of substance abuse, maybe some AOB or some drugs. Quickly get a pulse ox on him if we can and establish some ABCs.
Okay, I like that. So aggressive, all good information. I really like that. Anybody else got any other thoughts or things to add to that? I'm really going to force engagement tonight. Let me tell you, man. Scott, I can see your picture, your video. Do you got any input? Now he's going to turn his video off because he's not going to want to talk. Your mic is muted, sir. If you want to unmute your mic, I'll be able to hear you.
How about that?
There you go. Now I can hear you. Welcome, Scott.
The age and the dress and the proximity, all those things, but maybe issues with a specific substance like alcohol, for example.
Yeah, for sure. Thanks, man. I really appreciate it. Now I know your microphone works, so I get to call on you more than just that one time. So get ready for that. Anybody else have any other thoughts or things to add to that? I see a couple names. I know Mark. I know your microphone works. I know Suzanne, even though that's not actually your name. I know your microphone works. So anybody else want to throw any thoughts in there?
Hey, Sean, did you say something about the fact that he had snoring respirations?
Yeah, so it kind of throws that in there, right? It just says really you're noting some snoring breathing, like kind of as he, inhales, exhales, like he's got some snorous respirations.
I'd be concerned with a partially obstructed airway then at that point, so we might have to do some basic interventions immediately.
Okay, and I'll bet you know where I'm going to go with that. So hang on to that thought. Danielle, you unmuted your mic. What are your thoughts?
Possibly agonal breathing. So could it be possibly thinking about cardiac arrest, something like that? And then thinking about social determinants of health. We already know his background, so any health problems he could have, it's probably not been managed. So it could be worse than what a normal person's health might already be at that age.
Yeah, perfect. Welcome back again, Danielle. It's good to see you back this season.
Thanks. Good to be back.
Yeah, absolutely. So yeah, great point, right? Like we know that maybe even some general illness type stuff might be exacerbated by the fact that he doesn't have access to good, reliable healthcare or things aren't managed well. So definitely all, scene size up, I feel like there's a lot of stuff going on in our brains and we just got to kind of organize those thoughts. So all really, really good ideas in this situation. And that's kind of the idea I wanted to bring to tonight's presentation is, in EMT class, we made our patient assessment so much about these frickin' points on this skill sheet that we didn't allow people, or maybe your class did, but I'm making the assumption here, we weren't really allowed to have ambiguity and creativity and kind of do whatever we wanted to with patient assessment. It was almost like the path, the trajectory was already set for us in all of these patient assessment skill sheets. And so I wanted to break this down. I wanted to take apart the points of the skill sheet and kind of rip it up. And I wanted to break it up into 4 sections, right? Now, for each one of these sections, I want to come up with just a sentence. I want a sentence that sums up. So don't answer hastily. I want you to think about it because I want a sentence that sums up the purpose of these 4 sections. And let's start with scene size up. So obviously we got BSI, we got scene safe, we got number of patients, we got mechanism of injury, or is it nature of illness? We got additional resources and those. So let's sum it up. What is the sole purpose of scene size up? What do you guys think? If you could build a sentence that sums up the entire purpose of scene size up, what would the entire purpose of scene size up be? What are your guys' thoughts? And anybody can chime in. What do you got?
Safety and the immediate needs of the patient.
I like that. Safety and immediate needs of the patient. I kind of like that one. Who else has got some ideas? Anybody else? Before I give you, one of my EMT students gave me one the other day that I had never heard before, and I hate to say it, good thing they're not tuning in, but it was just hands down, I was mind blown that an EMT student came up with this. What he said was, it's what we have, what we need, and what we want when it comes to our scene, right? So what we have, what we want, and what we need from our scene. And he said that, and I turned my head and was like, oh my gosh, the light bulb came on for you so early, which means it's going to dim so quickly. But what we have, what we want, and what we need from the scene. That's all our scene size up is about. And I kind of like where Bruce is going with, you know, kind of the needs of our patient. I see that a little bit more as a primary assessment, but I really like the idea, right? So what we have, what we want, and what we need from our scene. Early on, do you need air medical transportation? Do you need law enforcement? Do you need extrication? Do you need traffic control resources? Do you need a power company to shut off power? All of those things, because they take time, need to be taken care of in that scene size up. So if you think of it like that, stop worrying about, especially if you're in the EMT program or you're moving on in EMS when it comes to these skill sheets. If you think to yourself, well, my scene size up is all about what we have and what we need and what we want from our scene, then brainstorm those ideas. And of course, you're going to use mechanism of injury, and you're going to use nature of illness. You're going to use all these things to drive what you need, what you want, and what you have when it comes to your scene. So the next broad one is our primary assessment or our primary survey. So let's sum it up in an entire sentence. Give me one sentence, and Bruce already talked, so he can't participate. Someone else in his room can. So don't back away from the buzzer there, Bruce. But what is the purpose of the primary assessment? Give me one sentence that sums up the whole thing.
Okay, we got one.
National
How about process to
Identify
identify the
life threats.
life threats there.
I like it. Is that Katie? Is that who's chiming in?
Yes, that was Katie.
Perfect, Katie. That's really good. So a process to go through our life threats. Okay. I really, really like that. Anybody else have any other ideas? We might stick with that one, but does anybody else have any other ideas when it comes to primary assessment? Bruce is looking around the room to see if anybody else has got any other ideas. The guy in the very back row. What do you got, Bruce?
Okay, Mitchell up here has an idea. That he says it's a process to identify the life or chief complaints of the patient.
So I like that. Scott, you unmuted your mic. What do you want to add to that, sir?
How about appropriate transport, whether it be not at all, ground ambulance, or call for a helicopter?
Yeah, nice work. So let's sum it all up, right? So let's take, it's the assessment and treatment of life-threatening injuries, comma, and transportation of our patient. I know it's a really long, drawn-out sentence, but it's my game, so I can change the rules. But yeah, so it's all about life threats, right? It's about finding our life threats. It's about treating our life threats. And then Scott is going to throw in at the end, it's all about, are we going to transport, is it a load and go or stay and play? Are we talking about refusal or something along those lines? So I really, really like that one. I think we're going to stick with that. Justin, what did you want to add, sir?
I just wanted you to repeat it.
Yeah, no worries, man. Yeah, so it is the assessment and treatment of life threats, bookended with our transportation decision.
Thank you.
Yeah, no worries. Anytime you need to repeat it, I am more than willing to. All right, so that's our primary assessment. Now let's go to the next big block. And if you're familiar with the NREMT skill sheets, this is where I differ a little bit. I truly think that we make this next part of the skill sheet way too convoluted. So I want to add everything because they break up like history taking and vital signs. Let's just all add that and let's just call it our secondary assessment, okay? Let's take all of it and just smash it into our secondary assessment. So what is the purpose, one sentence, what is the purpose of our secondary assessment, right? We've heard from Bruce, we've heard from Katie, we've heard from Mitchell, we've heard from Scott. Justin's repeat doesn't count, so he can still participate. What do we think? What is the purpose of our secondary assessment?
Would you say to go back, so like a fine-tooth comb, but to go back through and to check anything you missed, or just to reevaluate? If you're transporting ground transportation, you're kind of basically rechecking some of those things maybe you couldn't do exactly at the scene. Or
I like that. So I kind of like that go back through with a fine-tooth comb. I really, really like that analogy, actually. So let's keep that and keep that in mind. What else does someone want to add to it, or maybe manipulate what Justin just said? there's a lot of people that just like don't want to talk. And Kelly and Ken and Lane and both Marks and Susan and Taylor and Wiley's iPad, and no one wants to play tonight. I'm kind of sad.
I got you.
Yeah, for sure. What do you got, Brogan?
To reassess everything in the primary assessment to see if there's anything we missed and to reassess the treatment and transport decision.
Okay, I kind of like that one, and kind of like what Justin's saying, go back through with a fine-tooth comb. Now, the downfall is everyone in Stevens County now is limited from the game. You guys all used your phone of friends, and you guys are all limited. You guys can just log off and go home. No, I'm just kidding. Mark said to make sure you're going down the correct path, which I really, really like. So if we kind of sum this up, let's break this down, and let's just sort of one sentence. I love the idea of fine-tooth comb, and I also like, I'm going to input my own here, patient interrogation. So we got patient interrogation and fine-tooth comb, and like transportation decision, treatment path, all of those things we'll kind of add in there. And then, of course, the next easy one, and Brogan kind of already hinted at a lot of this, is what comes last is our reassessment, where we go all the way back, all the way up to our primary assessment. We revisit our airway, our breathing, our circulation, and all of those kinds of things. Reassessment's really easy, in my opinion, because you just start all over again. We're looking at trends. We're looking at improvements. We're looking at deterioration. We're looking at all those possibilities. So those are kind of my thought process, right? Scene size up is going to be all about what do we have, what do we want, what do we need. Primary assessment, the underlying idea is all about those life threats and all about that transport decision early on in your assessment. And I think if you put it in transport decision, if you put it in primary assessment, it forces you to think about transport early, right? I grew up in an EMS system where I had real long transport times. I know like Colville, you guys might have some long transport times. So if we put it real high up in the primary assessment, it forces our providers to get in the damn ambulance and start taking them to a hospital. It makes us save some of those procedures and those interventions that can be done in the back of an ambulance to save it till we actually are moving down the road. Secondary assessment is all about that fine-tooth comb, and then reassessment's all about starting all over again. Justin, what do you got, sir? I see your hand up.
What do you define as the long transport time?
Oh, man, anything over about 35 seconds. You know, really, I'm thinking about, I mean, if you're 20 minutes or less to a hospital, I feel like, you know, I understand why people do a lot of stuff on scene, but think about the golden hour, right? The golden hour is eaten by a lot of our destination limitations, right? We don't know how far out they are. You look at a good 30-minute transport is about the perfect length of time. So anything more than 30 minutes, I'm going to say, in my personal opinion, is going to be a lengthy transport. 30 minutes is, I feel like, a long time. Go ahead, sir.
You mentioned the golden hour. So what if it takes you 30 minutes to get there because it's a remote location, then you still have 30 minutes or longer. Well, for us from Harrington, we go to Davenport for the hospital typically, right, or we call in Life Flight. But so I guess you have to realize that on the way out there, if you have to kind of calculate those, think of those ahead of time, I guess is what you're getting at too.
Yeah, especially that scene size up, right? For a long, long time in my career, we used to poke fun at the guys and gals that would put helicopters on standby before they were even on scene. And I don't see a problem with that. I mean, I don't know about you, but I've requested a helicopter before and heard the worst thing ever, which is ETA is 45 minutes. And you're like, well, hell, I can be at a hospital sooner than 45 minutes. And so it's frustrating for our quick resource to be longer than that. We're talking about the golden hour, but I will tell you that in my opinion, one of the things I harp on to new EMTs especially is the Platinum 10, right? The golden hour cannot be controlled by EMS. We can't control how far away they are, how far away you are from them, how long until they call 911, did they have to hike to get cell phone service? Like, all of that are huge hurdles that we have to cross when it comes to the golden hour. But the Platinum 10 is all about how long is your transporting unit on scene, right? And if your transporting unit is on scene longer than 10 minutes, like, what did you do in that 10 minutes that couldn't be done in the back of an ambulance? I mean, and if you only have 10 minutes, you'll save that 10 minutes for very, very specific things. you can't backboard a patient in the back of an ambulance. So you got to do that on scene. Well, backboarding in some cases might take you 4 to 6 minutes. And if that's the case, you've already eaten a majority of your Platinum 10. Therefore, your baseline vitals maybe needs to be saved until you get in the back of the ambulance. Questioning your patient maybe needs to be done while you're doing something else to ensure that you're not eating that 10-minute time doing stuff that can be done in the back of your ambulance. When I got my advanced EMT certification, my FTO wouldn't allow me to start IVs sitting still to ensure I had the skill set of being able to start IVs in the back of a moving ambulance on a critical patient, because IVs is something, you know, I know Steve's an advanced provider, and I don't know anybody else by name, but those are things that need to be done while moving to the hospital. We may not have the time and the availability to do those while sitting still. So I think the golden hour is important, but I think that Platinum 10 needs to be something that's always in our heads to ensure that we're not wasting valuable time on scene with things that, quite frankly, could be saved for in the back of a moving ambulance. Any other questions on scene, like this bullet, these broad categories: scene size up, primary assessment, secondary assessment, or reassessment? Anything with these? You guys are making this really easy to ensure that I stretch this out an hour and a half. I was super concerned I'd get done early. You guys are doing a great job. So keep up the engagement. If you don't, I'm going to make you engage. There's still a couple names I still plan on calling on here shortly. So let's go back to our assessment here, right? So here's our primary assessment. An old shopping cart we talked about really has nothing to do with our scenario. The patient does not make any attempt to move and is not making any sounds other than some snoring noises as he breathes. He's got a radial pulse that's strong. There's obvious no bleeding or signs of trauma. Now, Bruce grabbed this idea here that he's got some snoring respirations. And I don't know about you, but it's also slightly concerning that, remember, the bystanders said he was up walking around initially, and then he went to this park bench and just kind of slumped into his position. Danielle was kind of talking about, are we looking at maybe a possibility of agonal breathing? Maybe we're looking at a pending respiratory arrest, or maybe even a pending cardiac arrest. But definitely some concerning pieces of this scene survey, right? And I think that really sums up with what are our initial concerns. We got a possible airway obstruction, definitely partial because he is still breathing. And we got some altered mental status going on here, leading ourselves to an unconsciousness or an unconscious state of our patient. So let's look at this airway, right? So I'm a big fan. I love this acronym. I love this saying, the keep it simple, stupid, right? Now, I wish we had a keep it simple, stupid sledgehammer that when we trained people in advanced airway procedures, we reminded them with that metal hammer about our simple airway procedures, right? So I like the NREMT pre-hospital trauma life support idea of open it, clear it, and maintain it. This is just talking about airway. So what does someone think? What is the simplest, and I mean the kindergarten simplest way to open an airway? What are your guys' thoughts? What is the most kindergarten way of opening an airway?
Tip his head back and just hold him upright.
Yeah, just for the love of God, head tilt, chin lift, or jaw thrust, right? Now, in this case, you might argue, you know, NREMT might lead you down the road that maybe he has a spinal injury. Bystanders saw him sit down. I'm not going to hold C-spine. It's overrated in this situation. So I'm a big fan of, we're going to lay him flat. Maybe it's on the ground. Maybe it's on your stretcher. If you're laying on the ground, please lay a blanket down or something so you're protecting him for some hypothermia. But just simply head tilt, chin lift, right? Or jaw thrust maneuver, depending on the circumstance. Now, what about, right, that's the answer to the first one. What is the most kindergarten way of clearing somebody's airway? What do we think? Be careful here, because it may not be what you think. What is the most kindergarten way, simplest way to open a patient's airway? What are our thoughts? Bill and Jordan, I'm going to pick on you. Nope, you, Bruce, you mute that microphone. I saw that. Bill and Jordan, what do you think? I'm going to make you talk. You can type it in the box too if you want to. What is the most kindergarten way to clear someone's airway?
Well, you have to talk to them and see if you get a response from them. And yeah, what's going on here?
I like that. So talk to them. What if there was something in his airway? What if talking doesn't work? You walk up and go, hey man, there's no answer. Maybe he's already laying down. So what's the simplest, most kindergarten way to ensure that we don't aspirate vomit? What do you think?
I'm not going to suction.
Roll them over, right? Kelly and Ken, is that where you're going?
Yeah.
Roll them on their
Yeah, nice work. Roll them on their side, right? Suction units, you might have a portable suction. It might be manual, it might be automatic, but it takes a little bit of time. If you want to do a fun little experiment after this is all done, because I don't want to watch you aspirate and die on camera, but fill your mouth full of a liquid and lay flat on your back and plug your nose, or have someone else plug your nose. And when you absolutely have to take a deep breath, when you unplug that nose, you're likely just to suck all that fluid right into your lungs. But think about if you were laying on your side. Then when you open your mouth to take that gas breath, some of that fluid is going to naturally clear out of their airways. So the most kindergarten way, keep it simple, stupid way of clearing someone's airway is roll them on their side, right? Pretty easy, pretty straightforward. Now, this one, what is the simplest way, the most kindergarten way of maintaining someone's airway? What do you think? This one actually starts to use a device. What is the most kindergarten way, Bruce, or I'll let, what are you grabbing? I don't know what that is. I can't see it. It's a C-collar. I like that, right? It's a C-collar. A C-collar would hold them in a nice, not really head tilt, chin lift, but a nice neutral position. I love the fact that Steve ran to get it. He knew where I was going. A nice, good, inline position. We put C-collars on our patients after we do airway placement. Why? Because it's an easy way to keep their airway nice and open. Now, if you're going to step on to the next level, so we go from kindergarten to third grade, we start looking at oral pharyngeal airways, nasal pharyngeal airways, and then as you graduate to like junior high and immaturity, you can start talking about paramedics and intubation. But we'll talk about that at a total different time. But for sure, immaturity and intubation and paramedics go hand in hand for all my paramedics that are joining in. But let's go back to open it and clear it for one, or open it for 1 second. I love this video. I used to personally think that head tilt chin lift was a great way of opening the airway. And I want you to watch this. So now, this person obviously is sedated, which is why you notice that the provider's finger is actually in their mouth. Now, what they're doing is what's called the tongue-jaw lift. That's probably found on your skill sheet for supraglottic airway. Should only be done on someone who's very, very unresponsive, if not sedated and paralyzed. I don't know about you, I'm not a big fan of sticking my fingers in patients' mouths because if they're hypoxic, they could seize, and if they seize, then you lose a thumb. But I want you to watch this this airway video. So the first thing you're going to see here is that's the tongue-jaw lift. So I hope you guys can see that. See how we got a good intact airway down here, right? We pulled those soft tissues, that tongue, the oral pharynx is clear. We got a good intact airway. Now, what they're going to show next is what we would think of as like a head tilt chin lift, right? Now, do you see here there's not really a good intact airway? We still got an oral pharynx that's closed. We still got some soft tissues that's kind of forced down against that oral pharynx or pharynx. So by itself, head tilt chin lift is actually not a great airway procedure. Now, jaw thrust, when it's done normally, also doesn't really give us a good intact airway. Notice how we're lifting that jaw up, and mind you, it pulls that, I keep pointing at the screen like you can see it. It could pull the tongue off the back of the airway, but it kind of forces that tongue against the roof of their mouth. So what they recommend is you got to get that mouth open. When you jaw thrust or head tilt chin lift, get that lower jaw open to give yourself a good intact airway, which is why personally unconscious patients with no gag reflex, even if you're head tilt chin lift or you got a C-collar in place, if there's no gag reflex, let's utilize some of these airway adjuncts. And here in a second, I'm going to talk about my favorite airway adjunct personally. And I feel like we don't use it nearly often enough, but we'll kind of talk about that. This last part of the video, what they're going to show is kind of this tongue jaw lift maneuver that they're going to do with, you can kind of see they're pulling on the back of the airway there, and they're going to head tilt, chin lift, and pull that jaw up. And you can see that now nice, good open airway. Again, I don't recommend or encourage you sticking your thumb in someone's mouth unless they are paralyzed and sedated, unless you're not a big fan of your thumb, because you never know what might happen in those circumstances. So one of the best, in my opinion, I'm not representing Department of Health or NREMT or anything, not this whole disclaimer crap, but the least invasive way to maintain an airway and a vastly underutilized airway is this one right here, our nasopharyngeal airways, right? Patients who are slightly to moderately to majorly inebriated, are drug intoxications, are barely conscious, are snorous respirations. Snorous respirations just telling us that that tongue is causing some partial airway obstruction. Now, I'm a big fan of going for the nasopharyngeal airway first, because if you go for the oropharyngeal airway, you're one of those individuals that's probably pretty familiar with the suction unit. And you don't forget to always turn your patient towards your partner when inserting the oropharyngeal airway, because you're likely going to induce some vomiting. And I'd much rather my partner have to change their uniform than I have to change my uniform. So kind of keep that in mind. But what's the problem with utilizing an NPA? Like this gentleman, for example, we lay him on the ground, we head tilt, chin lift him. Maybe he still has some snorous respirations. Drop an NPA in this guy's face. There's no facial trauma. There's no head trauma. There's no clear fluid coming from his nose or his ears. There's really no contraindication for dropping an NPA. And let's not forget, the indication is they have a gag reflex. And this right here is a really good tool to maintain a solid airway. And then we'll grab the new Brogan technique, which is pair that with a C-collar, right? Grab that C-collar, throw that C-collar on them, drop the NPA. Now, when you get to the hospital, make sure you pass on to the hospital. The C-collar is for airway maintenance, not for a spinal injury. Because I don't know about you, Steve, but I've done that to hospitals, and they're like, why aren't they backboarded? And you're like, because backboards suck, and they're not really worth it. But that'll be a different presentation for early 2021 of a New Year's resolution, less patients backboard. Maybe I'll make that in January. But let them know that it's for airway maintenance. It's not for a spinal injury. Okay? Moving our way through, that was the A, right? Now moving our way through B and C. This was also one of your test questions on your post-test. Now, small transparency. Did anybody download the post-test earlier today or yesterday and find out that I accidentally uploaded the post-test with the answers? And then I recognized it and pulled it. So some of you might have the answers right in front of you. If you do, I don't care. I mean, let's get real. The post-test is kind of silly anyways, but that was my own dumb fault. So if you got the answers in front of you, then this should be pretty easy. But what does breathing and circulation have in common when it comes to assessment? What are the commonalities between the two of those? Anybody have any other ideas? This one's a little bit difficult. These questions were actually written by Maurice. I just added them in my presentation. What do you got, Bruce?
Rate and rhythm.
One more. You got 2/3. Rate, rhythm, and
Quality?
Yeah, nice work. Rate, rhythm, and quality need to be assessed in both of these, right? Bruce, by the way, I know it wasn't you. It was Katie. You're just the speaker, so Katie gets all the credit.
You're taking my fun.
I know I am. Rate, rhythm, and quality needs to be assessed in both of these patients under breathing and circulation. Now, breathing, I feel like we got really caught up into, are they breathing? But we really need to pay attention. Is it a depth problem, right? We devote a lot of attention to the SpO2, and even Bruce mentioned it, which is great. I like it as a baseline vital. But let's not forget, is it shallow? Is it deep? Does it have one of those patterns that maybe we don't know by name? And I got a whole list of patterns and what they look like and what could be the problem and all that stuff here in just a second. but rate, rhythm, and quality need to be assessed in both. Now, when it comes to pulse, we've been doing this for a long time, right? You check a radial pulse in your conscious patients, a carotid pulse initially in your unconscious patients, and we want to know, do they have a pulse? I don't really care, me personally, I don't really care how many times a minute their pulse is beating. To me, that's a vital. What I care about is it fast or is it slow, right? Is it regular or is it irregular? And then, of course, is it weak or is it strong, okay? Is it thready? You can use different words there. So when you're looking at pulse rates, is it weak or is it strong, okay? Now, one of the things I want to bring back, and I know why we got rid of this and we haven't been teaching it, is I want you to log this in your brain. Now, we used to teach this, Brogan. I don't know how long everybody else has been in EMS. I just know Brogan personally. So was this taught in your EMT class, Brogan, the 80, 70, 60 rule? Do you remember that? If you got a radial pulse, blood pressures are said to be about 80 systolic. If you got a femoral pulse, blood pressures are said to be about 70 systolic. And then if you got a carotid pulse, you're about 60 systolic, right? Yeah, he's shaking his head, yes. My class was the same way. I did a little research, and it was because there wasn't a lot of like foundational science to prove this is an every time kind of thing. So they kind of took it out of education, which it's kind of a bummer, because I feel like in traumatic settings, when I want to be aggressive with my fluid management, it's a pretty good way of like, listen, if they got a radial pulse, I'm actually not horribly concerned about their blood pressure. If they're missing a radial pulse, I'm horribly concerned about their blood pressure. That's decompensating shock, in my opinion, and that's where we know we're a little behind the 8 ball. So if you've never heard of that before, you can look up the 80, 70, 60 rule of blood pressures and heart rates and gain that information. You can see this was taken from a source document in 2001, so it's a little bit old. But I think it's a good rule of thumb. I don't think it's a rule to live by and die by, but I definitely think it's got some good management properties and so on. So kind of keep that in mind. With breathing patterns, right? There are lots of other breathing patterns, and it is one of your test questions on your post-test. Here is a bunch of breathing patterns. If you want to take a picture of this slide, you're more than welcome to, or you can, if you know how Google works, you can just grab keywords here. But these are the list of breathing patterns. Bradyapnea, which of course means slow respirations. Tachypnea, fast respirations. Hyperpnea, which of course is going to be more on the depth side than it is going to the rate side. Kussmaul's respirations. Hypopnea, ataxic, biots, chain Stokes, air trapping, obstructive, sighing, apneusic. I love that one. Agonal, I probably mispronounced it. I don't care. And then apnea. You can see here on the right-hand side, it gives you some list of possibilities for what you're going to be looking for. To me, the big ones to be thinking about is those chain Stokes. Really be thinking about brain injuries. Chain Stokes respirations is really consistent in that Cushing's triad when you're looking at increased cranial pressure, so keep that in mind. And then Kussmaul's. The first thing I'm thinking is metabolic acidosis. At the EMT level, please be thinking about diabetic ketoacidosis. And that glucometer may not do you a whole lot of good. It may give you some false, or tell you high on the glucometer. So definitely be kind of thinking about that. But you can see there's a lot of reasons why patients can have these irregular breathing patterns. Here's just a list. I'm probably not going to talk or give report using these words, but if I'm documenting, I might call upon some of these words to make my documentation look vastly more intelligent than they actually are. But definitely some reference points when talking about breathing patterns. Just checking my time here. We are golden, 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 golden. All right. Any questions on respiratory breathing patterns? I mean, most of these, let's get real. If it's a pattern problem, the solution probably in a lot of these cases is bag valve mask, right? Oxygenation isn't going to fix a lot of these because giving a patient who, for example, who's Kussmaul's respirations, giving them 15 liters non-rebreather is literally like shooting a freight train with a BB gun, right? It doesn't do any good. You have to fix the pattern. The only way to fix a pattern or volume, of course, is going to be a bag valve mask, or in some of these cases, If they're still conscious, you might, if your protocols allow continuous positive airway pressure, CPAP can be an alternative. All right. Also found in that airway breathing circulation realm here is, I know for a fact Brogan learned in his EMT class that 15 liters non-rebreather cured all problems, literally, right? That alone will cure everything you can imagine. I wish we'd just give COVID patients non-rebreathers and the whole thing would be cured. It's not the wonder drug, right? This should not be the first thing that you grab and throw on all of your patients. If you're really aggressive, you might follow something like this on the right-hand side. If they're respiratory arrest, if it's a pattern problem, then bag valve mask. If they're 85% or lower, those patients can have a non-rebreather, right? Some of you may not quite be that aggressive. I like the 85% or lower, right? Then you can have a non-rebreather. If you're 85 to 92-ish, then guess what? You can have a nasal cannula. If you're down in the 87 range, I'll run the 6 liters nasal cannula into your nostrils. If you're at 91, I'll run 2 liters into your nostrils and see how that works for you. Oxygen is a drug. It's also a titrate to effect drug. So start with low dose, and if you're not gaining the results you're looking for, you can up those dosages along the way. If they're above 92%, I know American Heart Association says 94%, NREMT says 94%, so fine, put it at 94. But if they're above 94%, they don't need supplemental oxygen. And if you want to be a nice person and they're like, I really need some oxygen and oxygen will cure all my problems, then fine, give them low dose oxygen. Don't run 15 liters non-rebreather in these patients' faces. For COPD patients specifically, their SPO target, see it down there, SPO2 target is 88 to 92%. That's their normal FiO2 on room air. Most of those patients aren't room air anyways. They're at 1 to 2 liters nasal cannula. That's their norm. Let's not forget the pathophysiological response of COPD. These people are breathing based on their oxygen levels, which no one else in most of our disease processes are. Most of our patients are breathing based on their CO2 levels, and that's going to be 35 to 45 if you're using an end-tidal CO2 or waveform capnography. But that's what we're breathing on. To me, end-tidal CO2 is a far better tool when it comes to assessing our patient's need for oxygen than SPO2, but I know that sucker has to attach to a, I don't know, what is it, $10,000, $15,000 piece of equipment. So it may not be something that's utilized in all areas. So I understand that's definitely a limitation, but kind of keep those things in mind. If oxygen, right, if it's a volume issue, then use volume to fix it. A bag valve mask is going to be your solution for those abnormal breathing patterns, right? This is not this picture. This picture right here, it's kind of hard to see, sorry. I wrote it on my iPad, and I started like stuff in the EMT class and different programs that I do. We do a lot of brainstorming on whiteboards, and so I just regurgitated this. Respiratory failure is inadequately breathing. It's a volume problem. The patients that are that are respiratory failure are your patients speaking in 2 to 3 word sentences. They're in the tripod position. They got an abnormal rate. They're really slow, like less than 10. They're really fast, like in the 30s. Their tidal volume is way too low. In an NREMT test question, they're going to throw the word shallow at you. They got cyanotic skin. They got altered level of consciousness. Like, for example, this gentleman sitting on a park bench probably is a respiratory failure patient, right? Now, we're not going to know that, of course, till we lay him on the ground and see how he does. But your respiratory failure patients are treated with a bag valve mask, or as long as they're conscious and able to control their airway, and you got the protocol to allow it, that continuous positive airway pressure or CPAP is going to be a reliable source. So let's go back to our scenario here. You evaluate the patient for respiratory difficulty. Bruce already said we're going to lay him down. Let's throw an NPA in this guy to solve that snoring problem. We could throw him on some oxygen. If you're a good EMT, you might grab the bag valve mask and try a couple of breaths from that. We're going to put him on the stretcher. We're going to package him, head him to the hospital. En route, you do your the rest of your primary assessment, and then you start going, all right, so what the hell's wrong with this guy, right? So we kick off our secondary assessment. Now, the thing they're going to throw at you here is we're going to start our secondary assessment. I'm going to grab this little annotator here. We're going to start our secondary assessment with the fact that he does have a fairly strong smell of alcohol in his breath. Now, that doesn't mean that alcoholism is his problem. It doesn't necessarily mean he's heavily intoxicated. It just means that it's definitely something to keep in our brain, okay? So we got our scene size up with this guy. We got our primary assessment. Now we kick off our secondary assessment. And our secondary, I love secondary assessment because this is where the ambiguity of our assessment actually takes place. Now, whether you know you're going in one direction with one body system, or you think maybe you're going in another direction, or maybe it's cardiac and respiratory, possibly this or what, or maybe you're just going, I have no freaking idea what's wrong with this guy. No matter what plan you've got going or whatever obstacle you're facing, here's what I want you to do. From this point on, please, please stop leaning on the sample questions, right? I don't know about you, but in my opinion, those 6 questions they're baseline. We should be asking that for all of our patients, but that's not where our questioning ends, right? And we see a lot of new EMS providers lean on the crutch of sample, and we get there and go, so what do you know about the patient? We're like, we know their signs, their symptoms, their allergies, their medications, their past medical history, their last oral intake, and the events leading up to it. And you go, great. So what did you do with the other 45 minutes that you've been here on scene? And they're like, well, we've been talking about football. No, there's lots and lots of questions you could be asking these people. Lots and lots of questions you can be asking these people, right? So flip this mentality, right? Some people agree with this analogy. Some people don't agree with this analogy. I don't care. It's my presentation. I want you to interrogate your patients. From this point on, they're sitting across from you and they're hiding something. I want you to like walk in the room and like one light and loosen one leg of the chair, and so it makes them super uncomfortable. And I want you to grill them with questions. And the questions, you guys all watch these crime dramas. You see them start off with like, so what's your alibi? What's the alibi in this case? What's been going on the last couple of days, right? And then they kind of like ease into the more difficult questions. So what's your past medical history? And when you say chest pain, what do you mean pain? Like on a OPQ or ST assessment scale, right? But don't lean on those questions. There's a billion questions that you could be asking patients, okay? What really bothers me is EMTs, brand new EMTs, take a look at this secondary assessment on their skill sheet, and it's 5 points. 5 points. There are 42 possible points on the NREMT medical patient skill sheet, which tells the EMT that 2% of their assessment is the secondary assessment. So they ask crappy questions because it's only 2%. Now raise your hand if only 2% of your assessment is based on your secondary exam. Well, of course not. Like 95% of your assessment is done with your secondary assessment, because that's the fine-tooth comb. That's the EMS detective, right? If you're looking at this, it's a secondary assessment is like this iceberg, right? 2% of it is what body system do I think this is? Then what you got is baseline vitals, sample and OPQRST, differential diagnosis, 5 possible diagnoses that could be wrong with your patient, and then be the detective who starts marking these off based on evidence and questions and, you know, what were you doing and how did this start and what does this feel like and all those things. The DCAP BTLS assessment, I love DCAP BTLS, right? And that's where we're gonna go next, because in my opinion, we misuse DCAP BTLS. We only think this is for trauma because it's deformities, contusions, abrasions, punctures, burn centers, lacerations, and swelling. Those are all traumatic issues, right? They are, but if I tell you to do a DCAP BTLS, you put your hands on people and you start manipulating and pushing and pulling. Maybe you find a medical condition. Maybe you find a medical alert bracelet. Maybe you find something that gears you a little bit more towards what could be possibly going on. So that's what I want to chase real quick is This decap BTLS. First off, this is a sweet tattoo, by the way. I think I should get it tattooed right on my forearm. It'll for sure get me hired at my next EMS job. I feel like that's taking EMS one step too far. But let's look at these other acronyms, right? Decap BTLS is up there. TIC, TIC, tenderness, instabilities, and crepitus. I kind of like that one. TRD, tenderness, rigidity, distension. Now we're talking about the abdomen, right? PMS. Now, of course, we've pretty much changed this to CMS, which is circulation, motor, and sensory, but it makes you put hands down on the lower extremities. Maybe when you say, hey, which side of your foot am I touching, inside or outside? When you do that, maybe you feel the ankles for, I don't know, edema maybe. Maybe you look for you pull the socks down of the, you ever done that? Pulled the socks down on someone's leg and you've seen that constricting band? Maybe they've got some fluid retention or some poor circulation. Those are all things that you can find when I tell you to go search for the different issues that could be found with decap BTLS. Now, decap BTLS was predominantly found in what was called the rapid trauma scan. Well, stop calling it the rapid trauma scan. Some of us learned it as the detailed physical exam. Well, that sounds great. Does that not sound like a fine-tooth comb to anybody else? And with that, you got the head, eyes, ears, nose, and throat, which decap BTLS, blood and fluid, discolorization of the eyes, pupil check, foreign bodies, inside the mouth, teeth, foreign objects, swelling, lacerations, unusual odor. I mean, some of you work in some counties where unusual odor and lack of teeth probably is a baseline, so kind of keep that in mind. On the neck, decap BTLS, JVD, trachea placement. Chest, paradoxical motions. Is it symmetrical? Auscultate breath sounds. We're going to go there here in just a second. Palpate the pelvis. Is there pain? Is there tenderness? Is there motion issues? Is there, what's the word I'm looking for? Oh man, I just forgot the word. Incontinence. Upper extremities, decap BTLS, pulses, motor, sensation. Lower extremities, decap BTLS, pulses, motor, sensation. Edema check. Posterior, that whole 50% of the body that a lot of us forget about. Don't forget to assess the posterior, okay? This right here will help you in that secondary assessment. Now, if it's a generic, the patient's got chest pain, and you know that this is an isolated cardiac event, are you going to do a full detailed physical exam head to toe? I mean, maybe if you're bored, if you got nothing to do, something along those lines, maybe you'll do that. But for the most part, we know that we're gonna concentrate on that cardiovascular system. Where I really want you to harp on this detailed physical exam is go back to the, is it cardiac, is it respiratory, or is it, I don't know what the hell it is. If you don't know what the hell it is, do a detailed physical exam and go start building a possibility of lists, a possibility of injuries or illnesses, all right? If you're stuck on the decap BTLS thing, decap BTLS all of your patients, right? Absolutely detailed physical exam, rapid trauma exam, all of your patients to just make your lives a lot easier, all right? Now, other thing to keep in mind, I grabbed a couple of, now I really wish I could tell you that I kept these cheat sheets in my uniform. That's a lie, they're here on my desk, but cheat sheets, right? Acronyms like AEIOU and TIPS. This right here would be the differential diagnosis that we're building off of this guy. Unconsciousness could be alcohol, acidosis, ammonia levels, arrhythmias, electrolytes, endocrine, encephalopathy, infection. You can read, I'm not going to read all of them. But look at that list right here. That's your list of possibilities on this guy. And at the very end, in my opinion, that A in alcohol should be at the very end of your differential diagnosis. Because he could have something else. I don't care if you transported this guy 5 times for alcoholism in the last week. He could have something new. What other cheat sheets are there? The American Heart Association, a lot of their classes have these really cool trifold things that have your algorithms. These are really, really good tools. Spokane County, if you're unfamiliar with the Integrated Health Services Clinical Checklist, they've got a really good flip guide that allows you, I don't know if you can really see this, but a really good guide that allows like a checklist style of, If I think this is asthma, this says administer albuterol, get an end-tidal CO2, consider epinephrine, consider CPAP. It has kind of this guide of predetermined algorithms. If you think it's something, what are you going to go to next? I don't know about you. We're going to talk about GCS, but these cards that give you a GCS chart right on them and you follow them, these are really good. I'm a little bit old school. I've got this old school flip guide. I know you can still buy these at Barnes & Noble. This one I still do carry in my uniform, and this has got a laundry list of possibilities. Now, here's the cool thing. It's 2020. There's an app for this booklet right here that's a hell of a lot easier to operate, and you can get those downloaded on your cell phones to have these cheat sheets, right? I used to tell EMTs, I'm like, listen, if you got to memorize GCS and you got to memorize this. And I had someone at a conference say, if a pilot was flying the airplane you were on and had a mid-flight emergency, would you want them operating the emergency checklist from memory or following it by a card in front of them? And of course I went, I want them to follow a card in front of them, right? Those are the kind of things that put those cards, make those cards, and log or put those inside your uniforms and then operate from those to ensure that you're not deviating or forgetting something or missing something, kind of along those lines. All right. Here's this guy, baseline and beyond. We get a set of vitals in this dude. Blood pressure 142/96. He's in a supine position. Good to know. He's got a weak regular pulse of 88, right? Shallow labored respirations of 24. Skin is pink, warm, and dry. History has been difficult to obtain because, well, he's not answering our questions. However, you got a prescription here. I had to look that up. It's a prescription to be, he's being treated for tuberculosis. Written by a homeless clinic, was found in the patient's pocket. Now, maybe he has that med, maybe he doesn't have that med. Does it really matter? No, it tells us he is TB positive, which, good thing we're already worrying about our safety a little bit early on in this scenario. Now, let's harp on baseline vitals for a second, okay? If you want to see if something's getting better or worse, then you got to get a baseline. Me and the NREMT have a love-hate relationship where the NREMT says a blood glucose level is not a baseline vital. I get it. It's a procedure. Technically, it's an invasive procedure because you're taking a needle, you're breaking the skin, you're intentionally exposing yourself to their blood, and you're increasing their chance of blah, blah, blah. I don't know about, raise your hand if you think blood glucose level is a baseline vital sign. Does anybody agree with me? Yeah, everyone in Stevens County. Yeah, and so does Justin. That's all I care about at this point. I can't even see the other part of Harrington. Scott, I can just see your glasses, so I don't know about you. But blood glucose level is a great place to start. Not everyone who's a diabetic knows they're a diabetic. Not everyone that's having that's not a diabetic, maybe there's an underlying sugar problem they're not aware of, right? Check a freaking glucose. It's a really good starting point. The Glasgow Coma Scale. How many of you have the GCS memorized? I don't know why my hand is raised. I do not have it memorized. Of course you do, Brogan. I got this card right here that allows me to cheat, right? Pupillary check, a great baseline vital sign. Lung sounds, a great baseline vital. End-tidal CO2. I know some people that take a 4-lead EKG on 99% of their patients. I'm on board with that. If you got a $15,000 piece of equipment to hook up to, by all means, use the damn $15,000 piece of equipment for everything that it's good for so you don't miss something. Two things I want to harp on. Number one, if you're not calculating pulse pressures as an EMT, start now. It's really easy. Take your systolic minus your diastolic. The number you get is your pulse pressure. If it's narrower or if it's less than 25, your patient has shock. Somewhere, somehow in the body, they're suffering from shock. If it's wide, if it's greater than 50 to 65, if it's bigger than that, they got some increased cranial pressure going on, and somewhere in their brain is a dormant head injury that's going to cause you some major complications here shortly. Okay? That's pulse pressure. The other one is, I know this one sucks because, I mean, it's a math equation. MAP is really, this is the average pressure in a patient's arteries during one cardiac cycle. In a lot of articles and studies they're doing, it's considered a better indicator of perfusion to vital organs than blood pressure. Okay? You want a MAP of greater than 65. And that's how you figure out. Don't forget your order of operations, 2 times the diastolic blood pressure plus the systolic blood pressure divided by 3. That's probably going to be one of those cards that you use to cheat. But this, if you're giving saline as a treatment in your scope of practice, you're going to start seeing some more guidelines, in my opinion, on when to give saline based on more of the MAP and less on the systolic blood pressure. Okay? 2 things. That's it. I'm going to leave it alone. All right. So let's talk about this damn GCS. This is that thing I was telling you. So I read this article today. There was an interesting study. Now, this study is being done. I had to put notes. The University of Glasgow's Sir Graham Teasdale, who was the co-creator of the Glasgow Coma Scale. Okay? They teamed up with Dr. Brennan and Gordon Murray. And what they found was 11% of patients, and the number was 11,989 people, the GCS was calculated. 11% of them were missing, were unable to give them the verbal component. You can get eye opening and motor response because those are done without any interaction with your patient. Does that make sense? But about 11% of patients, you can't get a verbal response because of a brain injury, because of a stroke, because they're intubated, because of whatever. So just today, this article was posted just today, they gave this sliding scale for GCS. So here's what they did. They took the eyes and the motor and they say combine them, okay? So the score you get for I and M is there in the red, okay? If you get 2, 3, 4, 5, or 6 for eye and motor combined, add 1 for verbal, okay? And that can be your GCS. This is designed to be kind of a sliding scale, okay? If they're 7 for eye and motor, add 2 for a verbal, okay? If they're 8 and 9, you can add 4. If they're 10, you can add 5. See how that works? So you're kind of getting this sliding scale. So for patients who are intubated, patients who are unable to speak for whatever reason, this gives you a way of kind of guesstimating what you think GCS would be. Because look down here, because I really, really like this guide of a mild GCS score is between 13 and 15. A moderate is a 9 to 12, and then a severe is a 3 to 8. Severe, these patients right here, absolutely are helicopter candidates, ALS candidates, rapid transport candidates. Okay? So that's that new way. If you want to look it up, I think if you, I'm trying to think here. I'm sure if you just look up like the University of Glasgow's new GCS, you could probably find this article. It basically said it's a simple new strategy for inputting GCS verbal score to benefit patients with altered mental status, because now we can easily determine the GCS when verbal component, and we can accurately predict patient outcomes. Okay, I can try to put. I can't get access to my notes. I was going to try to put it in the note or the chat box, but you can do your own little research on that to try to take a look at it. But I hope that makes sense. It took me a little bit of reading that to kind of figure it out, but I think it's kind of a cool new spin on GCS that I think could be kind of beneficial for some of you guys in some of these outlying areas. All right. Lung sounds, kind of last thing I want to really, really harp on before we kind of wrap up here. So let's talk about lung sounds for just 2 slides. Number 1, this is the common picture we see when it comes to lung sounds, right? You got the posterior locations there on the right-hand side, the anterior on the left-hand side. I personally, my patients, if like perfect world, I want them sitting up. I want them bare skin with my stethoscope, and I listen on the back, right? I feel like it's less invasive when looking on the back than it is on the front. Now, what I kind of did here, and I hope you can see this, is I used some transparency slides and kind of threw the anatomical landmarks of your lungs on top of those spots. Now, Is it the posterior or the anterior side that looks like it's more thorough? What do you think? Is it the right or is it the left? Give me some fingers. Left or the other one? It's the other one, right? Like, you can get a better assessment. Now, I know some of you might be like, well, I listen, you know, a little bit farther down low or whatever. I'm sure you do, but I like the back. The back really does a good job of getting some of that outside, that third lobe in that right lung, or a little bit lower on that left lung. Here's the other one, though. This one I found. How many of you check tracheal sounds on a routine basis? Right? Maybe one or two people. But if you want to hear stridor and it's not audible, that's where you're going to hear it. You can see bronchial sounds up in that main bronchus, right? Way up here, you can see just above clavicles on each side of the sternum, over the manubrium, okay? Bronchoventricular sounds. You can see there, it's the blue regions, kind of right there in the middle. And then the vesicular sounds is going to be all those other areas. Now, I did the same thing here, and I transparently put this slide over it. I hope you guys can see that. Same thing here, where you can see it overlaid over the top of those lung sounds, okay? Listen to lung sounds with a baseline assessment, okay? If nothing else, it will allow you to be more fluent in what is normal, and so you can pick up on the abnormalities when it's actually found, okay? Please, please, please do check and listen to lung sounds on a baseline basis. So back to our homeless guy. Sounds super mean. I don't mean it like that. But when listening to his chest, you hear decreased breath sounds on the right lower part of the chest, crackles on the left lower part. You notice what may be some bloody sputum on his shirt. His abdomen is soft and appears mildly distended. The pelvis is intact with no evidence of trauma to the extremities or back. Pulses are present in all extremities. Because we got a good thorough assessment, a detailed physical exam, good baseline set of vitals, we've found lots and lots of possibilities here. In this guy's case, and really his underlying here is probably some exacerbation of his tuberculosis, with maybe some underlying cause of some alcoholism, but pretty straightforward in this case. But in a lot of these patients, especially in unconscious patients, the patient, when the patient cannot tell you what's wrong, chief complaint and a thorough assessment is going to drive your entire patient interactions. Okay? Don't delay transport for your secondary assessment. Okay? But unconscious patients or critical patients even, chief complaint and that thorough secondary assessment is really, really going to drive your patient interaction. Okay? In this case, you would probably concentrate on his central nervous system because he's unconscious. You might look at his digestive system, circulatory system, respiratory system. You might go in multiple different directions, be a lot more thorough when it comes to his assessment, or maybe you just kind of hone in on that central nervous system and his unconsciousness. I'm not sure what your guys' thoughts are on that, but I mean, this guy, pretty straightforward, pretty easy. I would say NPA, probably a bag valve mask candidate, going to be laid supine and then transported, probably lights and sirens to the hospital. Actually, I lied. I'm going to take him no code to the hospital. I don't think he warrants lights and sirens, but follow your protocol on that one. Okay? I decided today that I was going to try to, when I present, to give you guys some other ideas. That presentation is done, by the way. Other ideas, if you like podcasts especially, a couple of new podcasts I found that are super phenomenal. If you look up NCHD Paramedic Podcast on any podcasting app, the Serial Killer series is awesome. There's one on altered mental status. There's one on shortness of breath. But that Serial Killer series is all about like these broad categories of dangerous presentations from patients. And then Ginger Locke, I'm going to talk a lot about her mostly because her podcast is just rock star. Medic Mindset, her thinking series is really good. She has a thinking headache, thinking shortness of breath, thinking agitation, thinking chest pain, where she talks to practitioners and has them unpack the chief complaint associated with those. So unpack the assessment behind chest pain and so on and so forth. All right. Let's do the post test. You guys ready for this one? When should you start building your patient assessment? Who's got a thought? Unmute your mic, raise your hand, do something, type it in. I don't care. When should you start building your patient assessment? Justin, go ahead.
En route.
There you go. Based on what?
Information from dispatch.
There you go. Perfect. Nice job. Based on your information from dispatch. Solid work. Next question. What is the principal goal of the primary assessment? Katie in Stevens County, what do you think? Unmute the mic, Bruce. Let her yell it.
Process of identifying life threats.
Yeah, nice work. Just add the word treat in there and you got it golden. Identify and treat life threats. Solid work. Number 3, name 3 abnormal breathing patterns. Give me 3. Who wants to answer this one? Justin, are you going to jump on it?
Sure.
What do you got?
Cosmol, Biot, and Chain Stokes.
Perfect. Yeah, Kussmaul's, trust me, I only know because I heard it. I can't read. But yeah, Kussmaul's, Biots, Chain Stokes, air trapping, that list is back up there. If you're one of those people, you can take a picture of it again if you would like. But yeah, all of those were definite acceptable possibilities. Second to last one. How are assessing breathing and circulation similar? Bruce, what do you got, man?
I have rate, rhythm, and quality.
Money maker. You guys are killing it in Stevens County. Rate, rhythm, and quality are assessed. Nice job. Now, the one I didn't cover, this one you got to use your thinking cap. What are 2 ways of helping with scene safety? What are some things that you can do with scene safety? What do you think? Justin, you're reaching for the mic. I see it.
BVM.
Okay. No, go back to scene safety. All the way up. What are 2 things? Harrington, Washington EMS, I'm assuming that's in Harrington, is communication, which I like. Bill and Jordan, you unmuted your mic. What do you think?
You should be observant on your way there.
I like that. Observant on the way there. What else? Who has not spoke yet? Taylor. Taylor, are you even actually a real human? Type or unmute your mic. Taylor, what are your thoughts?
Yes, I'm a real human.
You are a
Can
real
you hear me
human.
all right?
Yeah, I can hear you great.
Perfect. I would say, let's see, helping with scene safety. You could ask dispatch as much information on the way there as possible. You can always ask more questions past what the initial scene size up is.
Yeah, I like it. Taylor, where are you from?
Washington, Spokane, actually, originally.
Oh, what agency do you work for?
District 3.
Oh, perfect. Awesome. Well, welcome.
Yeah, thank you.
Yeah, that's all great. I love our dispatchers, right? Like, let's annoy them a little bit. First off, it's their job. So pry them for some questions because garbage in, garbage out. They may not have all the answers. So, hey, has this address been flagged before? Maybe ask your crew members. Have you guys been to this address? But yeah, all of those things are great answers. So really, whatever you wanted to put down there, I would totally accept. But here's the deal. If you forget BSI and scene safe, you're going to have a bad time. So make sure that safety is a #1 priority. And your body substance isolation, let's be aggressive. I know N95s are uncomfortable, but let's wear them if it's needed, at least a face covering. Don't forget Washington State, we're required to wear those OSHA protected glasses. Don't forget our gloves. All those things are really important things. Next EMS Live at Night, you're going to get Gary Hertz. You've probably attended his presentations before. Brogan, I know you've attended like 1 or 6 months worth of his presentations before. He's going to talk about pediatric trauma. That's going to be on September 24th, starting at 6:30 like always. I will not be here that night. Gary's going to be presenting and Caitlin is going to be hosting. She's our admin here at INHS. Do me a favor, please make sure you submit your rosters as well as fill out that course survey. Also, if you like tonight's presentation, share it, invite people to the next one. Hopefully we'll get more than 14 locations on the next one. I can't thank you all enough for joining me tonight and tuning in. Please be safe. Travel safe home. If you got any questions, I'll be on for a few minutes. If not, Have a wonderful night, guys. Talk to you guys later. If you got
Thank
questions, let me
you.
know. You're welcome.